Welcome back to Single Payer Radio. Single Payer Radio is a project of Kentuckians for Single Payer Healthcare. We are an affiliate of the Kentucky chapter of Physicians for a National Health Program, and we're proud to be a community partner with Forward Radio WFMP 106.5. Please become part of our community. Go to forwardradio.org. We'd like your ideas, and if you can, chip in a few bucks. To join our healthcare justice movement, you can go to kyhealthcare.org or follow us on Facebook. Kay Tillow is chairperson of Kentuckians for Single Payer Healthcare, and you can contact Kay directly at nursenpo@aol.com. That's nursenpo@aol.com. Single Payer Radio can be heard weekly on Forward Radio on Mondays at 2 p.m., Tuesdays at 7 a.m., and Wednesdays at 11 a.m. We stream live, or you can listen to our episodes on the cloud. The views and opinions expressed here on Single Payer Radio are those of the speakers and not the station. We're recording today's show on Wednesday, August the 12th. Tragically, this morning there are over 164,000 COVID deaths in the U.S. Leading today's conversation, as they have been, are retired surgeons and emeritus professors at U of L School of Medicine, Dr. Michael Flynn out of Louisville, and Dr. Eugene Shively of Campbellsville, Kentucky. Today, Single Payer Radio is going international. That's right, Forward Radio is going to Canada, and Dr. Flynn will explain. Dr. Flynn?
All right, thank you. Before introducing our guest, let me make the usual disclaimer that any views that I express here are my personal views and do not represent the views of the Department of Surgery or the University of Louisville.
I have the same credentials that my views do not represent Taylor Regional Hospital nor the Department of Surgery at the University of Louisville.
So our guest today is Ted Young. Ted has been a general surgeon, thoracic surgeon, head and neck surgeon, endocrine surgeon at various times during his career. He is currently a retired clinical professor at McMaster University in Hamilton, Ontario, and has served in a series of leadership positions and surgical leadership positions, the chief of surgery, chief of surgical oncology at hospitals up in Hamilton. So Ted, thank you for doing this. We appreciate your willingness to spend some time with us. We have a series of questions about the Canadian healthcare system as it compares to our lack of a system. But we thought maybe we could start out by just giving you a few minutes to give us a kind of an overview, a background of how the Canadian healthcare system got started back in, I think it was 1984, and how it's evolved into what it is today compared to how it started out.
Sure. A pleasure to be with you. I'm delighted to hear someone's looking at universal health care south of the border. And I've been committed to universal health care since my medical school years, when my wife got appendicitis, which I missed because I missed the first lectures because I was taking tours across Canada as a guide, and kept saying, well, can you analyze the pain for me? So by the time I got her to a doctor, she had a ruptured appendix. Hospital care by then, this would have been in about 1970, was free. You didn't have to pay a hospital bill, and I'll go back to that in a minute. But the doctor's fee was not. And that didn't occur till, as you said, about 1984. And that bill would have put us in debt. Nowadays, people leave medical school in huge debt, but they will eventually be able to reap the benefits of being a doctor, and that's true in all professions, and I guess in all people that go to university and build those big debts. But I had university loans. I think my wife became a school teacher. The second year we were in medical school, I was in medical school. And when she got her first check, I think we had $3.40 in the bank. Now the difference, because I was a medical student, was the surgeon didn't send me a bill. Neither did the anesthetist. And that's maybe something we can come back to, the importance of doctors' willingness to give care to people when they realize there's going to be no monetary return. And medical care in Canada started back in 1929 in Saskatchewan. Back then, 60% of Canadians weren't earning enough to afford their health care. And in 1947, then Premier of Saskatchewan, Tommy Douglas, who's the grandfather of the actor Kiefer Sutherland, produced in the Saskatchewan legislature the Hospitalization Act to provide free care in hospitals for patients. And he then subsequently, in the early 1960s, brought in the Saskatchewan Medical Care Insurance Bill, which meant doctors would be paid by the government, not by the patients. So patient care would be provided for free. And the doctors fought that in the 60s in Saskatchewan, and that's the first area of Canada, one of the 10 provinces. The doctors went on strike. And strike for doctors is an interesting thing, and I briefly went on strike as a resident. We may not get time to talk about that, but the doctors went on strike, and it lasted a month. And then they gave in, and as doctors do, because they wanted to help their patients. And by the time they did, and subsequently, they said this was a good thing. And the reason Tommy Douglas, again, a personal story for Tommy, when he was a child, he got osteomyelitis in his leg. He was admitted to hospital, and happily, an orthopedic surgeon provided the care to that young man, brought up on a farm, as many in around Kentucky are. The doctor didn't send a bill to his family. He did it for free. And this, I guess, is at the basis of what we hope most people go into medicine for, to help people. So what went on after the 1960s? In the late 1960s, the federal government agreed to pay half the cost of hospitalization for people across the country. And as you mentioned, 1984 was the Canada Health Care Act. So by the time my wife was sick in 1970, hospital care was free. And that's a major thing for a country to do, because a hospital bill can be hundreds of thousands of dollars and can simply bankrupt not only the family, but the close members of the family that try and support them. What happened in 84 was the Canada Health Care Act that said doctors were prohibited from charging extra. And the doctors complained about that, okay, as you can imagine. But from that time to now, with few exceptions, we may be able to get to those, healthcare in Canada, hospitalization, medical bills, eye care in most circumstances, dental care for a selected group of people, and pharmacy bills for example, people over 65 and under 20 are covered. It's not perfect. It's not perfect because not everything is covered. And I personally believe that it would be just great if dental care was covered. Imagine all the people in their teens and 20s that get teeth taken out because they didn't have proper dental care when they were younger. But I think it's a good system. I've worked in it, as you can tell, for 45 years. And Mike said I'm retired. I'm only semi-retired. I'm both still a provider and a user of the Canada healthcare system. I work about a day and a half a week. As one of my former residents said, it's so medicine is now your hobby. And it is, because I like seeing people. I like helping people. What I find being semi-retired is I can talk to them on the phone more than I ever could before. So there's the background. I can give you more, Mike, but maybe you want to direct me a little in any direction you want.
Well, let's go back just all the things that are covered. So hospital and the doctor is covered. Now, I didn't realize that sight, hearing, and pharmacy were covered in some degree. I think
Yes.
you just said if you're under 20 and over 65, then you don't get any bills for the drugs. Is that right?
Now there is got to look at my notes here. I'm clearly over 65. I pay $100 deductible once a year. So come my birthday, the cashier starts over again. So the first bill I get for $65 for medicine, I pay. But once it gets up to 100, I then thereafter only pay a dispensing fee of $2.11 every time I get a prescription filled. Now, if I was made less than $20,000 a year, I wouldn't have to pay any of that. And again, it may change from province to province, and I live in the province of Ontario, but they recently introduced free drugs for up to the age of 21, which means 18-year-old that's afraid of getting pregnant can get her birth control pills.
How do you control the pharmaceutical cost? In America, we pay half of the entire drug bill of the world, and some of our drugs are just incredible. For example, Humira costs $60,000 a year.
Yeah. Well, as Melman, the hypochondriac giraffe on the movie Madagascar, voice of David Schwimmer, said, Canada, free drugs, cheap drugs. They are cheap because the federal government can make a deal with the drug companies. Now, Canada's population's a tenth of the United States and probably less than California. But certainly California and Canada can go to the drug companies and say, we're not paying this. We will use this drug or that drug, but this is the deal. So the drugs are cheaper in Canada because the government can negotiate with the drug companies and the generics. And when I go to get a prescription drug, I will probably get a generic if I'm getting something for acid reflux, for example. But the amount I would pay for it, if I had to pay for it, if I was 64, say, I'm sure is significantly less than it is in the States. And this is the same with all the drugs, including Humira that you described.
Now, Ted, it's my understanding that the Ministry of Health has a committee. I'm not sure what's a drug called, what it's called, and they do these negotiations. This is part of a government responsibility, as you mentioned, and they control not only the cost of the drug, but and I'm not. This is kind of my question, as the effectiveness of drugs or the appropriateness of drugs, so you don't have 5 drugs all kind of doing the same thing the way we do in this country that are it cost gazillions of dollars. And one of the questions I want to get to a little bit later on is about bankruptcy. But so this drug, who's on this committee that does this regulation and the negotiations with the drug companies?
Okay, now I'm not going to be able to answer all the questions you ask, but I can tell you that the people on that committee are experts. So these are drug experts. These are people that have done research on drugs, that know a great deal about the various drugs. Now, one of the big costs in drugs in both our countries at the moment are the new biologicals, the ones that are used for rheumatoid arthritis. And a company will tweak the biological a little bit so that their drug is a little different from the drug that costs a fortune, and they say, okay, we'll sell it for this amount. And then the Crohn's Society of Canada will say, no, we want to get the biological we're currently using because we know it works. And this committee will evaluate that. And of course, the drug companies will lobby aggressively to make sure they maintain their monopoly. And the people on this committee, we hope, are not being paid to make the appropriate decisions for a particular pharmacy, and I don't think they are. But it's monitored, and they say, you know what? These are the biologicals that are available, all the data, and they do pretty careful analysis. There are people on these committees who are epidemiologists. They evaluate all the papers on all the drugs, and they say the data shows drug B is just as good as drug A, and it's half the price. That's the drug we'll pay for.
Now, who pays for that drug? Is the federal government, or is there an insurance company that pays for the drugs? And does the insurance company or the federal government pay the hospital and the doctor?
Gene, it's the government is the paying insurance company. Now, you asked a minute ago about what the costs of the drugs are, and I can just briefly give you something from the Ontario budget. 40% of the Ontario, that's the province I live in, 40% of the Ontario budget goes to support healthcare. So that's a lot of money. The government of Canada spends 11.6% of its GDP, gross domestic product, on healthcare. In the United States, it's 17.8%, just for comparison. But in Ontario, of $64.8 million in the last year, 7.25% of it went to pay for drugs. 36% went to hospitals. That's for nursing care, ICU care, anesthetic equipment. 24% went to pay doctors. And there are another smaller group. So only 7.25% of the total budget in Ontario went to pay for drugs. That's all the drugs, all the expensive drugs. Now, there are a few rare diseases, some of these rare genetic diseases where children are born lacking specific enzymes, and there are drugs available, and they cost hundreds of thousands of dollars a year. Before any of those drugs are approved or to be paid for, it has to go through a committee that evaluates and says, is this reasonable to spend this amount of money? So there are several committees. And the same is true for chemotherapy drugs. All these new chemotherapy drugs for melanoma that have made an amazing difference in the survival of people with metastatic melanoma in their liver and lungs. I was on a conference yesterday, a patient who presented with brain and liver metastases from melanoma, alive for 2 years and asymptomatic on one of these new immune-based drugs that cost a lot.
Sounds like Jimmy Carter.
Well, yeah, exactly. And Jimmy Carter can afford those drugs. but this patient could not, but the Ontario government pays for it.
Yeah.
But that has to be approved. And the next new drug that comes along, they have to look at it and say, this is going to cost us this much money. And the doctors that want to use the drug have to make a case that it's worthwhile getting this drug for this disease.
Okay, let's kind of switch direction a little bit and get into one of the system efficiency issues. One of the things that we've learned as we've been doing these programs in this country from the mid 70s until the mid 2010s, the number of administrators compared to practicing physicians increased 3,000%, to the extent that today there are 10 bean counters, administrators, managers, whatever you want to call them, to every physician. So, and this has created huge inefficiencies in the system, to the extent that that some of the data that Gene has come up with, almost a third of the total amount of money that it flows through healthcare in this country is not spent on healthcare. So 2 questions to you. Number 1 is, what's the ratio of physicians to managers and bean counters? And number 2, if you know, because I don't know where Gene got all this information. What percentage of the money, the revenue that goes through the Canadian system, is actually used for healthcare and not? Maybe all of it is, because you sound like it's a much more efficient system than ours.
I'm not sure I can answer that question adequately for you. First, I'm going to give you a personal experience with administration in healthcare. When I came to St. Joseph's Hospital in Hamilton, the CEO was a sister, a nun. I guess she retired just before I came. So some of this is made up memory, but everybody said subsequently that if you needed a new OR, or you needed a piece of equipment in the OR, or you needed more beds or something, you went to Sister Mary Grace, and she would either say yes or no. That was it. That was it. You know, if you made a good case that you needed this, she would find it. She'd find the money somewhere in the Roman Catholic Church or in the budget or whatever. And she's been replaced now by, probably 50 people and numerous committees. You've all seen this. And you don't get an answer, in 5 minutes. You get an answer in months. And of course, the university involvement when you want to hire somebody. There are now 4 head and neck surgeons. I no longer operate, so I'm a bit 4 and a bit. But when we had to recruit, in the past 2 years, we've had to recruit 3 head and neck surgeons. The paperwork is immense. You have to go through the university. Then you have to do an assessment to see how much this new recruit is going to cost the hospital. Not how much better the care is going to be, how much less how the wait time to see a head and neck cancer surgeon will decrease by 10% or 50% or whatever, but how much it's going to cost, how many nurses will have to be available in the outpatient clinic, office space, how much more is it going to cost in the operating room? Well, let's see. When Young was operating 10 years ago, his average case cost $3,000. But now, with all these fancy staplers and so on, Bob Jones doing a case 5 years ago, doing the same case, it cost $10,000. So we got to take that into account. So, long time. So, how many administrators to run the Ontario Health Insurance Plan? I can't answer that. And I'm not sure how I could get that information, although if we ever have another one of these sessions, I will promise to work my way through the government to find out. But it's not as high as it is with any insurance company. You know, these insurance companies in the States, the CEOs are interested in making money for their shareholders and themselves. They're some of the highest paid CEOs in North America.
You're absolutely
And
right.
that's money lost for patient care. Right?
Yes.
Who owns these hospitals? Is St. Joe's still owned by the Catholic Church?
No, no, all the hospitals are now owned and run by the government. And in fact, I was just looking at some information talking about how in an article in one of the medical journals saying how the government has to increase their spending on what's called the capital, the actual buildings. And of course, long-term care, eh? All these long-term care homes, a very high percentage of the COVID deaths in Ontario were in long-term care homes. And they're funded and run by the government. Now, some of the long-term care homes are run by companies, for-profit companies. And that's part of the problem. That's why, for instance, in Quebec, on a night shift, you might have a nurse looking after 100 long-term care patients. I mean, these are patients that have diapers, for crying out loud. So hopefully this COVID will change how our long-term care facilities are run, but the money for them comes from the government. When I look at the figures for capital expenditure in Ontario, 2.9% of the Ontario budget, that remember I said was 65 million last year, 2.9% of that money goes to repairing, building new hospitals, etc. They're going to have to increase that and look after the long-term care homes.
One of the things that we often hear is that the Canadian system is so bad that Canadians come across the border to get care because they have to wait so long to get a total hip or coronary artery bypass, etc. Most of that is rumor. I've never seen any documentation of it. What's y'all's concept of that?
There are wait times, and the wait times are long, and it varies from province to province and from city to city. To be completely honest, I tell my colleagues all the time, we already have a 3-tier system in the Canadian healthcare system. We have the baseline that's provided for everybody, and I'll get back to the wait times in that situation in a minute. Then you have the tier where you know somebody in the medical system. I keep telling my family you have to have a doctor in the family at least every second generation, so you got access to the healthcare. So Billy Jones, who lives down the street, comes to me and says, funny, I got these funny smells. I keep smelling stuff and I can't actually, there's no smell around and so on. And I think brain tumor. I can call the hospital and fill out a requisition and say, I need an MRI on someone. Can you fit it in within the next couple of weeks? And they do. So that's the second tier. The third tier is people who say, I'm going to the States. The United States has the best healthcare system in the world, and it does for the top tier. Now, we're pretty close. Our best hospitals, I think, are as good as your best hospitals, but they don't have quite the money. Not every hospital in Canada has a robot the way we do at St. Joe's. And I know there are hospitals just over the border that have 10 robots. But do you need a robot to take out a right lower lobe lung cancer? No. Is it a little better? Maybe. So the wait times, now to get back to wait times, if you've got a hip that needs to be replaced and you've got a lot of pain and you're on a list in northern Alberta to get that done, that list may be 8 to 12 months. Now, if you're struggling to walk and so on, that becomes a major problem. And if you've got money, you may say, I'm not waiting 8 to 12 months. I'm going to, as someone in the Globe and Mail paper today did, it was reported as going, I'm going to, and I think she went to one of the Caribbean islands and had her hip done. Or she could go to the States and have it done. And there's no question, probably about $2 billion worth of health care goes south of the border to the Mayo Clinic, the Cleveland Clinic, New York, Houston, Louisville maybe, to get specialized procedures that they're not prepared to wait for. Some of that money is for patients procedures that cannot be done in Canada. So there are a small number of, for example, surgical procedures done in some of the hospitals on your side of the border that are not done here. Now, we have a couple up here. For instance, there was a neurosurgeon in London, Ontario called Charlie Drake, who developed an operation for base of brain aneurysms that nobody anywhere could do. I think he's now trained people around the world. So people came from the States to Charlie, but mostly it's the other way. The healthcare system in Ontario will pay for that procedure in a negotiated rate. They negotiate with the hospital and the doctor. If it's approved, and the doctors that do similar procedures in Canada say, we cannot do that operation, and Michael Flynn in Louisville can, so it should be paid. So some money goes south of the border. But if that same patient in Hamilton is on a waiting list for a bad hip or a bad knee, an orthopedic procedure, and they're the ones that, pain is a subjective thing. So you have to make your pain reasonable and make the doctor convince that it really is severe. And that's why orthopedic cases tend to be longer. And it used to be in Ontario, getting a cataract done was a long wait, 8-12 months wait. But if you go back to your orthopedic surgeon, your family doctor, and say, this pain is getting worse, can you not find a way to do me? And what will normally happen in that system is that patient will find a way to get done. Now, what they've done in Ontario, they have a wait time strategy. So our province, and probably the rest of Canada, but certainly our province has a wait time strategy for cancer, cataracts, and joint replacements. So if my neighbor Mary Jones can't get her total hip done at St. Joseph's Hospital in Hamilton for 8 to 12 months, and when she talks to surgeons, he says, no, that's just my waiting list. I can't move you up. She said, what about one of your other colleagues in the hospital? He says, oh, they're all the same. She goes to the wait time process. They will find her an orthopedic surgeon somewhere in the province who's got a shorter wait time. And the same thing happened with cataract. The wait time for cataract now is a matter of months because they just said, okay, you've got to fix this. They go to the hospitals for cancer and say, we're monitoring your wait times for operations for cancer of the thyroid. If your wait time is greater than 3 months for an operation for cancer of the thyroid, then you lose points and the hospital loses funding. So the same is true for a major tongue cancer. The wait time has to be within a certain period of time. So that's an initiative that the government said, okay, we have to fix our wait time. And the other thing is it's personal connection. I saw a patient who came from an hour-and-a-half drive away to see me. I did a tongue cancer 4 years ago, and he's got a new tongue cancer. And I said, okay, I biopsied this today. I'm going to book you for a CAT scan. And his wife said, is there any chance we could get it today? Because it's a long drive. We're right down near Buffalo. So it took me one phone call to say, I have a man with a tongue cancer. He needs a CAT scan for staging before his surgery. Can you fit him in today? And they said, sure. Now, if you're a really busy surgeon working your 60 to 70 hours a week and someone asks you to do that, the answer may just be, no, I can't, but my secretary will try to get it done as soon as possible. That's the advantage of being semi-retired. I got that time to make that extra call. And in the healthcare system, if you make the call to the radiologist, the radiation oncologist, the internist that you really want the patient seen because you think the patient's got chest pain and doesn't need to go to emerge, but you might have to operate on them, the Canadian system will respond to that. And that's, I think, because there's still a major percentage of the doctor population that really wants to help people. I'm not sure I've answered your question, but you can see I'm
Mark might
committed.
An announcement here, and then we'll move on.
Okay.
Okay, you're listening to Single Payer Radio on WFMP 106.5 in Louisville with Drs. Michael Flynn and Dr. Eugene Shively in conversation with their guest, Dr. Ted Young, in Hamilton, Ontario, Canada.
You brought up the robot. In America, that's become a real trend, and we have most general surgeons now doing inguinal hernias and gallbladders with the robot. How do they deal with a situation like that in Canada?
Because the hospital has a tight budget, the robot that we have was bought by using philanthropic funds. So the surgeons that wanted to bring the robot in to do robotic prostatectomy, which I think is I've watched this operation many times, I think is a real advance. Taking out a gallbladder with a robot or a hernia with a robot is bizarre and a waste of money. Hey, I'm an old man, I can say that. But so the robot is bought with funds. The instruments, because the instruments are expensive, hey, they're disposable. At least they will be for the near future till the monopoly runs out, and then they'll come from, maybe not from China now, but from some country that will manufacture them for a third the price. The money for those comes from raised funds from the hospital foundation. And I think that's the same across Canada. That's what every hospital has a foundation that raises money for things like that, buying fancy equipment, etc.
All right, let's change horses or change direction again a little bit. One of the banes of my existence in the last 10 years or so before I retired was the electronic health records. In this country, it is a nightmare of complexity based upon the need to deal with all of the billing issues that's been incorporated into most of the systems that we're dealing with. What goes on up in Canada? Do you still have the other issue with the electronic health system is it's a passive system, and as you just indicated, picking up a phone and talking to somebody and getting something done is a way of avoiding some of the lawsuits that have occurred as a result of people passively putting information into an electronic health system that doesn't connect up with whoever it was supposed to go to on the other end. So could you give us a kind of an overview of where the Canadian system sits with electronic health records?
It would be best if the governments across Canada negotiated and everybody got a common electronic health care system. It's down to the hospitals. So the hospitals they raise money, they take it out of their financial budget. And we now have Epic, which is probably the one you're using in Louisville.
Yes, that's exactly the same one.
It's a very complicated, very complete electronic system that was designed by lawyers and hospital administrators to minimize the risk of being sued and to make maximum money for the hospital, so that every little thing that was done that's my take on it. It's got some great advantages. I learned to use it because I no longer have a secretary. I can actually book things. I've learned how to book outpatient procedures and endoscopies. But it's not user-friendly. At least it's not doctor user-friendly. We do not use it for billing. And you mentioned billing. And let me just emphasize some of the pros, the advantages to the system I live in. One, no elaborate bills. I had one secretary that ran my office. I had 3 secretaries in a total of 45 years. My wife is the business manager. She does the billing. She orders things. But one payer. When at the end of the day, I submit the work I've done, and the government plan pays me.
How long does it take to get the check?
That's very interesting because I worked through what's called the Regional Medical Associates run by the university. So they have a billing program that we bill into, and they submit it all. And the arrangement with them is that I get the money in my bank account that month. Now, the complicated surgical cases that some reviewer somewhere in the system says, no, I don't agree with that. We're not going to pay that part of that operation, and then I have to fight that. So that does happen. But the straightforward consults, visits, straightforward appendix, straightforward gallbladder, straightforward thyroid is paid immediately, and it's transferred to my account. So that's one of the advantages. No co-payments, no deductibles, almost no paperwork. And for the patient, and just because I'm it's important that I mention this now, because you asked it one of your questions, they have free choice. They can go and see any doctor they want, anytime, anywhere, right? So if they come to me and I give them an opinion as to what they should have with their thyroid and they're not happy with that, they can go and see another surgeon or another surgeon. And that's maybe a bit of the disadvantage. Because they don't have to pay for that, they can doctor shop. In fact, that's rarely a problem. And it's a great advantage. In other words, no health insurance says you have to have your gallbladder taken out by Mike Flynn. I'm sorry, that's the arrangement we have with the Louisville University. You can have it taken out by the doctor in your little town, or you can go to the most advanced hospital in the province. So electronic healthcare records, they're a great advantage. I can sit here from home and go in and find out what's happened to any of my patients at any time, their blood work, their x-rays, whatever.
Now, when the patient comes into your office, do you fill in the electronic medical records, or does the nurse do that?
For the past decade or more, all of my work has been done through the hospital. So I run through clinics, a cancer clinic, and so on. So when the patient registers with a clerk who registers the patient in the system, when I see them in my examining room, all that information is in front of me on the computer. What I do, and I do the ordering, I order blood tests on the computer, and I order x-rays on the computer. Then they go out and they check with the receptionist to go get their blood work done, and they say they'll be called with the date for their CAT scan or whatever. I then pick up my cell phone, click on Dragon on the Epic, and dictate my note, and then send copies to anybody that I think needs a copy of that note. And then the visit's finished. The only thing that then has to be done is when I come home, I give the paperwork to my wife and say, I saw this patient, bill this.
Do you use Dragon for your history and physicals?
Absolutely.
Okay. Now
And have for, it's about 2 years now since we got Epic. And I was one of the first people in the hospital to use it because I said, I can't type. You know, when I send an email back to Mike, I'm doing it with 3 or 4 fingers. But so they said, okay, we're paying for Dragon for all emergency physicians. You ever seen a written note from an emergency physician? It's unreadable. Now they're all readable because they all have Dragon. Yeah. And we're going to give it to you, et cetera, et cetera. And now they've rolled it out through the hospital. All my progress notes, all my histories. When I get when I get a blood work here through my fax at home, and it's a low vitamin D or a low TSH or a very high TSH or something, I just go on my computer, go on Dragon and say, this patient's vitamin D is only 30. I'm going to phone the patient and tell them to increase their vitamin D to such and such. And I send a copy to the family doctor. It's there in the record. And all that information is available to anybody that needs to see that patient in the future. So that's an advantage.
You mentioned malpractice. Malpractice is a big problem in the States, not really from the actual cost of lawsuits, et cetera, but it's defensive medicine. For example, particularly in the ER, if somebody comes in with benign abdominal pain, most of our patients end up with CAT scans to defend themselves. Do you have the same problem in Canada?
I'm sure that happens sometimes. I tell my residents when they're dictating an operative report They're dictating it for or a history and emerge. They're dictating it for three reasons. They're dictating it so they remember when they see the patient again what they thought at the time, what they thought and found at the time. They're doing it also for anybody else that sees that patient in the next hour or year, what the status of that patient was then. And I said, you're also dictating it for the insurance company, medical records, the law courts, so that so if the patient's got an injured arm, say what the sensation is in the hand. Can they move all their fingers? You're doing that to help the patient and you, but you're also doing it to make sure that you're covered. Does every patient need a CAT scan with abdominal pain? I don't know the answer to that, but most patients, I think, with abdominal pain, with any sort of concern, end up getting a CAT scan because they're available now. Ultrasound CAT scan. Do people do things to prevent being sued? Probably, but probably not nearly as much as south of the border, because our insurance costs, which are I think $30,000 a year, for example, are about 10% of what they are in the States, and Canadian patients tend not to sue very often.
Ted, earlier on, you alluded to bankruptcy briefly in passing. In this country, 60% of bankruptcies are related to medical issues. We have, depending upon the year, somewhere between 200,000 to 600,000 or 700,000 bankruptcies, medical bankruptcies a year. And, and this is all related to the deductibles, the co-payments, the surprise billings, and all of the issues surrounding the process of having over 1,000 for-profit health insurance companies all out to get as much money out of the system as possible. How much of an issue is that up in the wilds of Canada?
Well, no patient suffers bankruptcy because of their inability to pay their hospital charges or their doctor's bills. None. However, and I was surprised at this, that about 17% of bankruptcies in Canada are health care related. I thought, what's this all about? Well, it's because some of these patients then can't go back to work. They lose their income.
Yes.
They've got debts because instead of saving their money to buy a TV, they buy a big flat screen on time, and the same with their car and their house and so on. And then they lift something at work and they pop a disc and they get back pain and they say they can't go back to work. And so the cost of looking after the disc is nothing, but they now no longer have an income. So, but no cost of bankruptcy because they can't pay the doctor.
Yeah, so these are directed, the result of the secondary effects of whatever the medical issue, not because they can't pay the insurance companies or they can't pay the doctor or they get surprise medical bills or anything related to their medical care is not a direct effect of a bankruptcy in Canada.
Yeah, exactly.
I've been told by some Canadian physicians that there was a system where you could only make so much money in a year, and then after that, you just took off the rest of the year.
No, you know what? That happened to me, and it's a long time ago. It's like 15 or more years ago. It was the Ontario government. It was run at that time. It was not Liberal Conservatives. It was the Socialist type party, NDP, National Political Party, and they said, all right, after doctors make bill $400,000, and just for your listeners, remember that that's total income. That's before you pay taxes. That's before you pay your office expenses, your secretary, anything you have to do in your office, which in most doctors, surgeons practice is about 30% of your income. So they said after $400,000, we will only pay 2/3 of what you bill us up to another $50,000. And after that, beyond $450,000, when we paid you $450,000, we will only pay 1/3. So that happened. It happened for a couple of years. And I fought it, we fought it, and so on. But it hit me because I was working, I don't know, 80 hours a week at that time. I was working full out. My family didn't see me very much. And my wife said one day I was going down, finishing dinner, going down to do 2 tracheostomies. And she said, you realize you're only going to get paid 1/3 of the amount for doing these. I said, yes. She said, you'd do this for free, wouldn't you? I said, yes. So, yes, some people took time off. What the presumption was by the public at that time was that, oh, they must be doing something wrong. They must be overcharging. They must be, it was ludicrous. The fee for doing a thyroidectomy back then was about $250. It was peanuts, Michael. But we were working hard because we could and we wanted to. Who wouldn't want to use the skills you spent all your life getting so you can do to help people? What the government did, they said, oh, but by the way, if you go up north, we'll pay you full fee for anything you do up north, and we'll pay you a bonus. So guess what I did? I went up to Kapuskasing, which is way the hell up north in Ontario. And I loved it up there. If I'd done that when I was a resident, I may have ended up in a little small community like Eugene, because I did everything up there. I hadn't done abdominal surgery for ages. I did an emergency colostomy in a patient with obstructed colon. The government pays to fly those people out of Kapuskasing down to the big cities. But I couldn't put a guy with a big distended colon on an airplane where the decompression might blow his colon. So I did it. And I loved it. And they loved having me there. Thanks for coming up here, Doc. And it gave the doctor there, the only surgeon in that town with 4 GPs, a break. And so that's what you do. But that only lasted a very short period of time.
All right, Ted,
and I think it was aimed at the ophthalmologists who were cranking cataracts out as fast as possible, the radiologists who were billing for a big practice of 10 radiologists. One radiologist would get this big high amount back from the government. They say, oh, you must be doing something wrong.
All right, we're getting close to the end here. We got our last 5 minutes. Let me ask you one quick, it's kind of a quickie, and then we'll see where it goes from there. I was watching television last night as they were making the announcement of Biden's new vice presidential candidate. I was watching the news. And for every 5 or 10 minutes of news, I had to listen to another 5 or 10 minutes of drug company advertisements for everything from Humira to Eliquis to some sort of magical constipation medicine that's going to make you feel wonderful for the rest of the day. Is that direct-to-consumer marketing an issue up in Canada as well as it is here?
No. The only ads we get are the one we watch United States TV. Just a quick comment, because I was thinking about this. I've been thinking about this for a couple of days. So there are 3 people or entities involved in a medical encounter: the payor, the patient; the payee, the doctor; and then these third people, which are the insurance companies or the government. And I'd far rather have a government, no matter how many mistakes they make, being that third person than an insurance company who's only interested in money. And one of the advantages of the healthcare system being universal is, for example, when COVID hit us, 6 months ago now, all the visits to doctors, all the visits to hospitals, all the surgery, it just went almost to zero. And what the government did, and OHIP, the Ontario Health Insurance Plan, did, they said, okay, we don't want patients going to see the doctor and spreading this virus. We don't want people going to the emergency department. In fact, the emergency visits dropped like a stone. It was fascinating. It was a lot of the people that go to the emergency department maybe didn't have to go until they were really sick. The government said, okay, we will pay the doctors to do telephone or video consultations, and visits. Imagine that happening with an insurance company in the States. Maybe it did, but I find it hard to imagine. So a lot of family doctors had problem with this. They had to leave, they didn't need nurses, so they had to lay them off and so on. But the Canadian systems was able to say, all right, these people need care. We will pay for it to be done over the telephone. So the patient didn't have to come from 100 miles away or 20 miles away, pay for parking. They could phone and talk to the doctor and say, I'm a little concerned about my incision. You could say, okay, you got a cell phone? Take a picture and send it to me. And you can phone back and say, no, that's okay. Or, yeah, that looks a little red. I'll order you some antibiotic. Or, I'm concerned about you. I am going to have to see you. I'll see you at such and such.
All right, Ted, we're down to the line here.
Okay, buddy.
Listen, thank you. And we will do this again. Okay. We're probably looking at a couple of months down the road, but this has been very helpful. You're a great guest and we appreciate it. It's been very informative, and Mark is going to strangle me if we don't get off the air.
Ted, thank you very much.
Oh, my pleasure.
Doc,
Great to talk to you guys.
perfect. If you like what you hear on Forward Radio, WFMP 1065, please support our all volunteer-driven community radio station. Go to forwardradio.org and become a member. For more information about Kentuckians for Single-Payer Healthcare, go to kyhealthcare.org. Please wear a mask and please stay safe, everybody. Healthcare is a human right. For Single Payer Radio, I'm Mark McKinley. Thank you.